And those are red blood cells passing through. That's Oprah, by the way. Those are the red blood cells passing through. Okay, that wasn't, I don't know. All right, let's take a look at the core objectives from the syllabus, cardiovascular system objectives, and then we're going to look at them in more detail. Identify and describe the major gross and microscopic anatomical components of the cardiovascular system and explain their functional roles in transport and hemodynamics. Oh, this is cardiac muscle. You could see the intercalated discs right there. Intercalated discs, cardiac muscle. Oh, and this is an artery, this is a vein, and this is a nerve over here on the right. This is what blood looks like in a microscope, and this is what blood looks like in a scanning electron microscope. This is some math. While we're at it, this 5 represents the number of liters you have in your body, if you're an adult, of blood. 5 liters of blood. You also pump about 5 liters in about a minute. So the cardiac output across 1 minute is about 5 liters. This 5 stands for the 5 million red blood cells we have in 1 microliter of blood, which is written with the Greek letter mu, microliter, 5 million red blood cells. 15 is the number of grams of hemoglobin that we have in a deciliter of whole blood, which is a tenth of a liter or 100 milliliters. So that's 15 grams of hemoglobin per deciliter of blood. 45 is the percentage, it's known as the hematocrit, the percentage of whole blood which is red blood cells. 150 to 45,000 is a typical normal for platelet count per microliter. The platelets topic is coming up. 10,000 is a nice number of white blood cells to have. It's definitely up there per microliter. If it's twice as high as that, it's considered too high. That means, you might have an infection or something. But we'll review the normal for white blood cells in a bit. Now, this is showing you the formula for calculating cardiac output. Here, it would be 5,000 milliliters, which I converted up here to liters. And 70 is the number of milliliters found in a typical, squeeze or stroke of the left ventricle. But 75 is probably more typical. 70 is the heart rate, the number of times across a minute that it will squeeze. So the heart rate, 70 squeezes or strokes per minute. 75 would be the stroke volume. That's the number of milliliters ejected per minute. And that would equal the cardiac output of 5,000 milliliters, or in this particular case, technically 5,250 milliliters, or 5.25 liters per minute in this example. CO stands for cardiac output. SV stands for the stroke volume, which I just mentioned is the number of milliliters ejected. How do you calculate the stroke volume? A full left ventricle might have 125 milliliters of blood in it. If 50 are left after systole, then that would mean that 75 got ejected out. And So the 125 is the end diastolic volume, and the 50 is the end systolic volume, which means the volume at the end of the squeeze, at the end of systole. And so stroke volume is technically end diastolic volume minus end systolic volume, or the amount of blood that gets ejected out of the heart in a typical average-sized man at rest. The pulse pressure is what P stands for here. Pulse pressure. Pulse pressure could be determined by simply taking your systolic blood pressure, which in this case is a larger number, 120, minus 80, the diastolic, and that would give you the pulse pressure. In this case, that would be 40 millimeters of mercury, and you can palpate that easily with radial artery palpation. MAP is the mean arterial pressure. In order to calculate that, you take the diastolic blood pressure, which in the example we were looking at was 80. So diastolic blood pressure multiplied by 2 plus systolic blood pressure divided by 3. Usually this is about a little bit higher than the diastolic because the systolic adds to it. So in this example, it would be 80 plus 80 plus 120. That adds up to about, what, 280 divided by 3. And if you take 280 divided by 3, that's going to be about 93.3, or 93 and 1/3. So that would be the about 93 would be the pulse pressure. If the pulse pressure is below 70 or below 60, the person could feel uncomfortable, like they're in shock if they're an adult. And you can look this up on Wikipedia. On Wikipedia a few years ago, it was listed as 60, and then someone changed it to 70. So basically, if someone's blood pressure is sort of like right here, this 82/58, this was me after I had food poisoning, and I had Atlantic Ocean, Pacific Ocean, which means, of course, vomiting and more. And my blood pressure was 82/58 with a pulse of over 118 or so. Normally, at that time, my blood pressure was normal or a little below average, but like 105/60 something. It wasn't super high to begin with a pulse of like 50, but with a pulse double normal and a systolic blood pressure that low, that was due to loss of fluids. So it is very important to check someone's blood pressure, but on the other hand, in this country, of course, it's a big industry and they keep lowering the normal, but that's another topic. Red blood cells live up to about 4 months. They are removed from the circulation by mainly the liver and spleen. The funny thing is, before we're born, the spleen and liver are mainly producing red blood cells. Breakdown products from the red blood cells are recycled and reused. Some books mention the bone marrow as another place where red blood cells are killed or eliminated. The bone marrow in adults is the red bone marrow is basically where the blood comes from. And this shows the source of most of the future red blood cells. Thank you to the red bone marrow for housing those important cells. And you can see they're lifespan. They live about 120 days, and then they go to the liver, macrophages in the liver or spleen, and then this book mentions even the red bone marrow, in print. The red blood cells get old. As you can see, pretty much all aspects of the red blood cell, including the iron, the amino acids, and even the heme group, get recycled. How the blood is recycled. And a lot of recycling going on. And the urine ends up being a little colored because the bacteria works on the bilirubin, and then the urobilinogen ends up in the urine. Starts from. Number 2, describe the general functions of the cardiovascular system. Obviously, one of the purposes of the cardiovascular system is to pump blood as far away as the posterior tibial artery, and you can palpate those pulses, and that's basically blood flowing to the body tissues through the artery. And describe the formation and composition of the plasma. Typical whole blood sample, there is about 15 grams of hemoglobin protein and about 4 grams of albumin protein. Now, technically, the hemoglobin is not in the plasma, but the main player as far as proteins in the plasma are the albumins, and you can see they help maintain the osmotic pressure, basically keeping the liquid in the capillaries so it doesn't go into the tissue space. And there are various types of globulins that can act to transport iron, like I said earlier, and other things. Almost all the clotting proteins are made by the liver in whole or in part. And the largest volume is fibrinogen, a large protein which is the very last step in blood clotting. It turns into fibrin thanks to an enzyme called thrombinase, and then it will help us clot the blood. And there's also all kinds of salts or electrolytes and other nutrients in the blood. Of course, oxygen is mostly on the red blood cells, but some of it is dissolved in the plasma, and a whole bunch of carbon dioxide is traveling in the plasma as bicarbonate ion. About 7% is dissolved as carbon dioxide. There's even nitrogen gas. 78% of the atmosphere does end up in the plasma. And there are enzymes, hormones, vitamins, and of course, waste products as well in the blood. Number 4, list and describe the events in hemostasis, including the coagulation of the blood. Blood clotting involves several clotting or coagulation factors, most of which are proteins. Blood clotting can be activated in one of two ways, the extrinsic or the intrinsic pathway. Both of these lead to the formation of prothrombinase, which will basically lead to a common pathway. Let's take a look. First, a quick review. Hemostasis is the stoppage of bleeding, and there's 3 overlapping phases. The vascular spasm, as you can read here, it says blood vessels constrict to limit blood escape. The platelet plug formation, platelets arrive at the site of injury and stick to the exposed collagen fibers. They stick to each other. The coagulation phase, this is a coagulation cascade of events, converting inactive proteins into active ones, which ultimately forms fibrin from fibrinogen, and that fibrin forms the strands of the blood clot. The muscle is right in this middle layer here, and it spasms to constrict, to limit blood escape. Then platelet plugs form. This is where if you take aspirin, it slows this down, which could be bad, could be good, depends on your medical condition. And here you see the fibrin strands in the clot, and this is the coagulation phase. The last step in this cascade is fibrinogen turning into fibrin, and then of course red blood cells get caught up in that net. And that's what is called a blood clot. If it's sort of unwanted, we might call it a thrombus. Blood clot is sometimes called a thrombus. The coagulation phase is basically blood clotting. Network of fibrin, which is insoluble protein, forms a mesh. Fibrin comes from a soluble precursor, fibrinogen. In other words, fibrinogen is dissolved in liquid, just like salt or sugar dissolves in your hot tea. But fibrinogen turns into fibrin thanks to an enzyme. The mesh traps the erythrocytes. The net traps the leukocytes, the platelets, the plasma proteins that are called fibrin itself forms the blood clot. You can see all the components of it. You see the fibrin here, you see the platelets, and the erythrocytes, or red blood cells. And now you know why the platelets are also called thrombocytes, because they're involved in forming a thrombus, or in this case, a wanted blood clot. The erythrocytes are caught up in there too. It's one of their side jobs to help prevent blood loss by volunteering, so to speak, to get caught up in there. You can see this one is caught up right in there, stopping the escape of other blood cells out of that cut. This woman is cutting her finger by mistake. The extrinsic pathway is initiated by damage to tissue outside of the blood vessel. You can also have damage inside of the blood vessel. If the damage is around the blood vessel, in other words, the tissues around the blood vessel get crushed, that's not a good thing. And they release a chemical called tissue factor, factor 3, also called thromboplastin. And in the presence of factor 7 and calcium, what can happen is it can cause the factor 10 to become active. And once you get past there, I mean, the last two steps is usually all I want you to know, which is basically fibrinogen turning into fibrin. And the step immediately before that is prothrombin turning into thrombin. You'll notice that fibrinogen is called factor 1, Roman numeral 1, and then prothrombin is called number 2, Roman numeral 2. There's about a dozen of these. The other thing you should know is either the name tissue factor, factor 3, or thromboplastin. And let's take a look at this area for a second. Yes, the other thing you should know is that platelets can initiate this as well. And of course, also that calcium is involved. Calcium is actually called factor 4, as you'll see in a moment. Extrinsic means the vessel itself is okay, but the area around the vessel was crushed. And you'll notice these last couple or 3 steps are basically the same. It's called the common pathway. Prothrombin turns into thrombin, and then thrombin is basically what causes fibrinogen to turn into fibrin. It's that simple. And this is showing damage to the inside of the blood vessel. So this one, the inside of the blood vessel is actually damaged. And this, as you can see, the blood clot is closing the area so that this blood vessel can heal up. The damage can be of the blood vessel or of the tissue around the blood vessel. Either one of those can initiate blood clotting to save your body from bleeding to death. Number 5, demonstrate a working knowledge of the A, B, O, and Rh blood groupings. About 85% of people are Rh positive, but about 15% of people are Rh negative. Let's look at the different blood types. 6, trace the pattern of blood flow within the heart. We're going to study the cerebral circulation for the final exam, the hepatic circulation for the digestive exam, the pulmonary circulation for the exam following this one. So all we've got left is the systemic and coronary. As far as the cerebral is concerned, we will study this later in the year. But if you can't wait, basically the vertebral arteries feed the brain as well as the internal carotid arteries. Describe and show understanding of the cardiac cycle, including basic rhythm of the heartbeat, pressure and volume changes, heart sounds, and electrocardiogram. Got all that? List and describe factors involved in regulation of stroke volume and heart rate. Our body at the aorta and at the carotid artery monitors the baro or pressure, the chemo or pH and chemicals, and sends signals to the brain and to the spinal cord. The vagus nerve slows down our heart. The sympathetic nervous system can speed up the heart, and that is direct by stimulating the heart itself, and sometimes indirect by adjusting the blood vessel caliber. These cells in the heart, called nodal cells, lose their temper about once every second, and they're located in the SA node, and they are what are sometimes called the main pacemakers. The action potential is propagated from cell to cell through gap junctions. At rest, the nodal cell is different than at the time that it is firing. So it basically goes through what a neuron goes through, except it goes through it due to leakage every second. In other words, sodium sneaks in, and then sodium pours in. Then potassium pours out. And this happens repeatedly. Calcium is also involved. This is the so-called leakage or pacemaker potential. As I said earlier, sodium sneaks in and then it pours in along with calcium. Then potassium flows out. This happens over and over and over again every second. Before we're born, it starts, and once it stops, that's about the time we're declared dead, when the heart stops. There is another pacemaker that takes the signal, holds on to it for a moment, and then signals the rest of the heart. that delay is very important for the atria to empty. The atria are these upper chambers. And this one all the way over here is on our body's left side. And this atrium on the left is actually stimulated by the SA node as well, almost at the same moment. We'll talk about this later. The action potential spreads. Cardiac muscle cells at rest, as you see, have this closed. Thanks to an electrocardiogram, we can see when the blood flows through the atrium. No, we don't. We actually see the electricity. We see the electricity that flows through the atrium. And this represents the electricity flowing through the ventricle. So the electricity flowing through the atrium and flowing through the ventricle precede the actual squeezing of those two parts. Here you can see the ventricle is full of blood and pushing it out. This is what starts thanks to the QRS. The QRS gets all this going. Electricity, just like lightning, precedes thunder or squeezing. Here, the atria have already emptied. Now, they don't empty 100%, so this is a little bit false. But anyways, when they empty, that means the P wave has already been there and done that squeezing. So at this point, the QRS is about to do its work. The QRS causes the ventricles to contract, or is associated with electricity flowing through the ventricles. Here, the atria are squeezing, which means the P wave was just there a moment ago. Cocaine and norepinephrine and being nervous, nicotine, all of these things can affect those nodal cells, thyroid hormone, caffeine, and cause our heart to beat a little more vigorously or faster. So does being nervous, the adrenal medulla releasing epinephrine, norepinephrine, all these things are sympathetic innervations of those nodal cells. End diastolic volume is the amount of blood we have in our ventricle right before it empties. After it empties, it's called end systolic volume. So the amount of blood that gets pushed out every time it squeezes is stroke volume. Stroke volume can increase or decrease. Venous return, more blood flowing into it, seems to stretch it more and makes it work better for some reason. Probably because additional cross bridges form and the ventricles simply contract with greater force. There are various things that can affect the stroke volume, and here's a list of some of them. Increased sympathetic stimulation, increased calcium in there due to, as you can see, the sympathetic nervous system stimulating it. And that causes additional cross bridges to form, and just like a skeletal muscle, the cardiac muscle is stronger the more you stimulate it. There are medicines to oppose this, which are scandalous. Some of them, such as amlodipine, does not belong on the market. It's also known as Norvasc. Nature should decide our heart and our body, not a pharmacist or a guy with a white coat. But yeah, calcium channel blockers oppose this, but they're usually not good for you. Variables that influence stroke volume. Afterload. Afterload is the resistance in the arteries to the ejection of the blood. So if you're blowing into a straw, the thicker the straw, the easier it is to empty out your lungs. People with asthma know how hard it is to breathe when they have asthma, an asthmatic attack. Atherosclerosis, which is deposition of plaque on the inner lining of the arteries, goes up as we age. Arteries can become more narrow in diameter at any moment, increasing the resistance, and the stroke volume would decrease because it just has a difficult time emptying into a high resistance pipeline. So you could think of the heart as the pump, and the pump doesn't work well if you have a clog in the pipes. So in summary, cardiac output is determined by the resistance downstream, how much it's getting from the return from the body, the veins, and of course things that stimulate it in a stimulatory way, such as the sympathetic nervous system or the parasympathetic nervous system, which can slow it down as far as the strength of squeeze. The speed of the squeeze is chronotropy, chrono meaning time, and inotropic means the power of the squeeze itself, the strength of the squeeze. So we can increase the speed and the strength of the heart per squeeze, how quickly or strongly it empties, to increase cardiac output. And to decrease cardiac output, you lessen those chemicals, you lessen those stimulations, and the heart will squeeze slower and less vigorously. An alarm clock is a perfect way to make your heart beat faster and stronger. List and label the anatomy of and give the functional roles of the different types of vessels. There's three layers: the tunica interna, also called tunica intima, the innermost layer. The tunica media is usually smooth muscle or elastic fibers or both. And then the tunica externa, the outermost layer, adjacent to the surrounding tissue, also called the tunica adventitia or adventitia. The arteries, like I said, the tunica media is a blend of smooth muscle and elastic fibers. The aorta is basically all elastic tissue, whereas, for example, the radial artery is more muscular. And the veins have these things in them called valves, and these are the capillaries. The veins have valves. The capillaries are basically endothelium and some basement membrane, which means some material that holds it down to the surrounding loose areolar connective tissue. And you can click these if you have the PowerPoint, which I uploaded. This is showing the artery in a microscopic specimen. Compare and contrast fetal versus adult circulation. I usually cover that, but I go over that at the end of the year again. Demonstrate understanding of blood pressure and its functional interrelationships with cardiac output, peripheral resistance, and hemodynamics. Just to let you know, blood pressure is not a disease. It's a vital sign. It's not a disease, blood pressure. And one more thing, we're going to now look at these in more detail. Are you ready to look at these in more detail? This is a future topic. Describe how blood pressure is regulated. But if you cannot wait, these are the factors that determine blood pressure. We have the volume of blood. How much blood is there to pump? The skeletal muscle pump. The respiratory pump, which is basically inhaling and exhaling. And venoconstriction, the constriction of blood vessels. These can increase venous return. They can also stand by and watch as the decreased parasympathetic impulses or increased sympathetic impulses in hormones can increase heart rate and stroke volume, causing that blood that just came back to be pumped more vigorously out of the local area. And into the rest of the body, into the body. Increased cardiac output will result. And the mean arterial pressure will go up because with increased systemic vascular resistance and increased heart rate, both, the mean arterial pressure would go up a lot. What makes the systemic vascular resistance go up? Basically, blood vessels vasoconstricting, an increase in the total blood vessel length, and also thickness of the blood. The thickness of the blood can be influenced by the number of red blood cells per milliliter, per microliter, and also increase in body size, as in, for example, obesity. Blood pressure can be controlled by the nervous system, and the various parts of your body coordinate this. The medulla oblongata contains the cardiovascular center, which is basically a bunch of neurons that regulates our individual person's heart rate, the contractility of it, and the blood vessel diameter. As you can see, one of the main areas for control of the cardiovascular system is right there in the medulla oblongata. It monitors blood acidity, blood pressure. It could even monitor joint movements. From higher brain centers such as the cerebral cortex, the limbic system, and the hypothalamus, it receives input. The output is either slowing the heart down, the vagus nerve, or speeding it up, the cardiac accelerator nerves of the sympathetic nervous system. Vasomotor nerves from the sympathetic nervous system can cause vasoconstriction. So basically, heart rate, contractility, and vasoconstriction could be thanks to the sympathetic nervous system. The parasympathetic nervous system mainly just decreases heart rate. Baroreceptors, which means pressure receptors, are important. Pressure sensitive sensory neurons that monitor the stretching of the walls of the blood vessels and the aorta, and they send their signals to the brain. It's interesting, cranial nerve 10 has to do with taste. Cranial nerve 9 has to do with taste as well. So eating things seems to basically calm down your medulla oblongata, and what it ends up causing is a slowing of your heart rate via affecting the SA node. Now you can also have a scary thought, and the scary thought can go stimulate the sympathetic trunk of ganglia, which can stimulate the other sympathetic chain of ganglia, sympathetic trunk ganglia nearby, and that will speed up the heart. The stimulus here is a disruption of the blood pressure, and this is monitored by baroreceptors in the carotid sinus and the arch of the aorta. And they can stimulate the adrenal medulla to release epinephrine, norepinephrine, and also stimulate the cardiovascular center in the medulla oblongata. And the heart and blood vessels will react, and the response will be increased blood pressure and a return to homeostasis. So everything is back to normal. That's called negative feedback, called homeostasis. Now, if you want to click this, you'll read more about it or hear more about it here. Now we're back talking about hormones. We're talking about hormones and hormones again. These topics will come up later in the year, when we discuss the kidneys. I will come back to this topic. But yeah, blood pressure is auto-regulated by your own body, not by a guy in a white coat or a pharmacist giving you pills. Physical and chemical stimuli can lead to this auto-regulation. First one, describe the functions and components of blood. After blood is spun in a treated test tube, it has 3 layers, the middle layer being the buffy coat. The bottom 2 layers are called the formed elements or the cellular elements. And the blood plasma is more than or about half. It's called the top part. And that top part is 92% or so water. The rest of it is proteins and other salts and solutes. And the top part, like I said, either the formed elements or cellular components. The bottom part, actually, the part where everything seems to fall. And you can pause this and try to learn all of the things in the plasma. Note that there are nutrients such as minerals, at least one major one that is not found, electrolytes that is not found in the plasma, and that would be iron. Iron is found mostly in the red blood cells, although there are proteins that carry iron found in the plasma. Number 2, describe the functions of blood. Didn't we just do that? Well, let's do some more functions then. Blood transports oxygen, carbon dioxide, nutrients, hormones, and heat, and also waste products, and it helps regulate the homeostasis of body fluids. It's a buffer for pH, body temperature, and water content of cells regulation. It also protects against excessive loss by clotting, and it uses white blood cells to protect against infection. Besides the coagulation cascade, it also forms platelet plugs. Describe the physical characteristics and principal components of the blood. Didn't we sort of do that already? Well, the physical characteristics. Principal components. Explain the origin of blood cells.
Of course, we know which came first, the chicken or the egg argument, and we also know the sperm and egg business leading to the whole body. At some point, we have these hematopoietic or pluripotent stem cells. Some of them can become red blood cells, and others can become lymphocytes. The ones that lead to lymphocytes are slightly different than the ones that lead to red blood cells, platelets, and all the other white blood cells.
Here's some cardiovascular math. What do these mean?
Each one of these means something, and we should probably try to review these at some point. For example, this right here is a blood pressure that's usually considered near the bottom of normal. This traditionally was considered at the top of normal. However, I've realized after seeing my mother up in this area and myself after vomiting and having some illness at this area that there are exceptions to the rule, and also babies have a lower blood pressure than this. This used to be considered average. However, you cannot say that there's one average for everybody, but it is good to keep these in mind. It really does help because a lot of other people view it this way, and you're going into a field where there's a lot of opinion and a lot of misinformation, and you have to be aware that others believe that there's a new normal and it changes every time the drug companies decide to change it. But we'll go over what all these mean at some point. It's called, I call it cardiovascular math. If not now, then in the future. I think you should know all these, what they mean.
Withdraw blood into a syringe, a treated syringe, a special syringe available at the hospital or the healthcare center. Place it into a glass centrifuge tube. The centrifuge spins round and round. Gravity normally would take too long. The centrifuge spins for 10 minutes and all the red blood cells fall to the bottom. On top of the red blood cells, you would see the white blood cells and the platelets. The plasma is the liquid upper half, the watery half, 92% water. Right on top of the red blood cells would be the platelets and the white blood cells. The normal for these vary from lab to lab. Some of them might say, for example, 145,000 to 500,000 per cubic millimeter for the platelets. It really depends on the lab. But generally speaking, these are roughly about what the normals are for most laboratories per cubic millimeter, which is also called a microliter, written with the Greek letter mu and then L meaning liter. The number of people that live in Chicago and the surrounding areas is over 6 million, but Chicago's 3 million, so let's say a few of the suburbs would be about 5 million. So I remember this as being that number 5 we saw earlier. And then that helps me remember 5 million. And if you check it out, the number of white blood cells is about the number of policemen. And then the number of platelets, PL, get it? Platelet PL is about the number of people who speak Polish fluently. Preparing a blood smear is actually covered in the lab video that I prepared, sort of an introduction. And this is what you would see. Very pretty. This wonderful slide shows the origin, differentiation, and maturation of all of the formed elements of the blood. This particular book calls this stem cell a hemocytoblast, and it's the myeloid stem cell that leads to the red blood cells, the platelets, and 4 out of the 5 white blood cells. You can see the nucleus is being kicked out here, and this reticulocyte, having a lot of these, indicates recent blood loss or maybe donation of blood. And the megakaryocytes seem to explode slowly or drip into 1,000 little pieces called platelets. And the eosinophils, basophils, neutrophils, and monocytes are the cells that also come from this cell. All these cells here are the children or the offspring of these cells. Various chemicals or hormones, biological chemicals, help determine what this cell here becomes. So if you donate a lot of blood, this chemical will go up and you'll make a lot of red blood cells, for example. That's called rouleau. When the red blood cells stack up like this in the capillaries, it's called rouleau. Not to be confused with le roux, which is totally different. Rouleau is different. In one red blood cell, there's about 280 million hemoglobin molecules. Wow. Technically, each hemoglobin is made of 4 subunits called alpha and beta. So we have alpha 1, beta 1, alpha 2, beta 2. There's alpha 2, beta 1, beta 2, alpha 1, and there's a heme group in there. What is that? Well, in humans, the heme group has an iron in the center, and it's very interesting looking. It's an organic molecule. You see it? And it's similar in some ways to plant chlorophyll. Look at the chlorophyll in plants. It has a magnesium in the center. So you could think of our lung like an upside down tree. This is the next unit. And in both cases, you have either hemoglobin or chlorophyll going into those leaves or alveoli through the branches or the bronchi of the trunk of the tree or the trachea. Very cool stuff. How does erythropoietin regulate red blood cell production? Well, it does. Erythropoietin, also called EPO, comes from the kidney and it goes up due to a stimulus. Can you identify the stimulus there? How's your eyesight? Right there. Decreased blood oxygen levels. You see that? So you see, erythropoietin causes the bone marrow to make more red blood cells, to carry more oxygen. And once there's plenty of red blood cells, then the kidney lays off, backs off a little bit, doesn't release as much erythropoietin. That's how erythropoietin regulates erythrocyte production, EPO. Also called erythropoietin. And these pluripotent stem cells are in the bone marrow, for example. They're hiding in there, housed. Now, what if you donate blood and you keep donating blood and you're not supposed to donate that much blood? You'll make a lot of these reticulocytes as your body struggles to replace the blood that you donated or lost. "100 milliliters of blood contains approximately 15 grams of the protein hemoglobin in it, which is used to carry oxygen. Each hemoglobin has an iron in there, and the red blood cell itself is shaped like a biconcave disc, which supposedly allows the red blood cell to carry oxygen more efficiently." This is the shape of the red blood cell if you cut it, and then the hemoglobin and the iron containing heme. Hemoglobin has 4 subunits. Hemoglobin has 4 subunits: alpha, alpha, beta, beta, 1, 2, 1, 2. And the red blood cells are very interesting. They can also regulate blood flow via the release of nitric oxide, a mysterious hormone, gas, neurotransmitter. Nitric oxide causes vasodilation, which improves blood flow and enhances oxygen delivery. Red blood cells also contain a special enzyme that is going to come up in Unit 3 called carbonic anhydrase, which catalyzes the conversion of carbon dioxide in the presence of water into carbonic acid. Carbonic acid then turns into bicarbonate ion, which is abbreviated HCO3-, and most, or about 70% of the carbon dioxide in our blood is traveling incognito or in disguise as a bicarbonate ion, which is very interesting for Unit 3. And this right here is showing the bicarbonate being released into the plasma. So if you read this bottom line here, the majority of blood carbon dioxide is carried incognito, in disguise, as bicarbonate in the plasma, thanks to that enzyme called carbonic anhydrase made by the red blood cell. Very interesting stuff for Unit 3. The aforementioned reticulocytes enter the circulation and mature in about 1 or 2 days. Erythropoiesis is the name for the production of red blood cells. This is an animation that you can click. Erythropoietin is made by the kidney and also the liver. And it causes us to make more red blood cells. More red blood cells means more oxygen carrying capacity. It's a response to decreased oxygen delivery to the tissues. With the extra red blood cells and extra oxygen delivery to those tissues, including the kidney and the liver, erythropoietin levels will fall. Describe the structure, functions, and production of white blood cells. These are fairly easy to draw. Basically, the basophils are very blue looking, full of blue spheres. The lymphocytes have a gigantic nucleus. The monocyte macrophages usually have a U-shaped nucleus. This one looks like the letter U, I suppose. The eosinophils, sometimes it looks very rosy red after you add the dye. And the neutrophils, they don't like either dye. So that's why they're called neutrophils. By the way, the acidophilic dye, or eosinophils are also called acidophils because they like the acidic dye. Basophils like the basic dye, so they're called basophils. Another name for eosinophils is acidophils because they like the reddish dye. Each one of these has a different purpose. Describe the structure, function, and origin of platelets. Yes, platelets. Just like all the blood cells do, the platelets also come from the pluripotent stem cells. The problem is they're not really cells, they're fragments of a cell, yet they're still called thrombocytes in some places. In frogs, they do have a nucleus. In humans, they have a nucleus as megakaryocytes, but the megakaryocytes start breaking apart into many, many pieces. The way I remember it is the megakaryocyte, megakaryocyte, which means big, big, big nucleus, meganucleus, and then it breaks up like you're dropping a plate. A purple plate is dropped and broken into pieces. By the way, if you look on the left side, you see the nucleus being ejected from the red blood cell. That's a different topic, but that's basically how the red blood cells are made. The nucleus gets kicked out. No! Anyways, let's get back to the platelet. As you can see, it's broken up into little pieces called platelets. And colony forming, what is this? Megakaryocyte. Colony forming unit, megakaryocyte. This is what is sort of like, I don't know, a hormone, a chemical, which causes you to make more of those platelets in case you need more. The megakaryocyte, the red bone marrow, splinters into 2,000 to 3,000 fragments. So maybe in some people, the fragments are a little larger, so they break up into 1,800 fragments to create the platelets that contain many vesicles but no nucleus. Platelets are used to clot the blood. Under the influence of the hormone thrombopoietin, hematopoietic stem cells differentiate into platelets. Platelets only survive for about a week or so. We have to keep making more and more platelets from those megakaryocytes, which break apart into those platelets. Here you can see the megakaryocyte breaking up into platelets, not all at once. But slowly it'll break up into pieces, and aspirin makes the platelets non-sticky. Aspirin makes the platelets non-sticky. So besides the red blood cells, the red bone marrow is also a source of the platelets. And it's the megakaryocyte that becomes the platelets. And it differentiates from previous cells, such as the megakaryoblast, to become what are also called thrombocytes. But these are the platelets. They don't have a nucleus, but they have a lot of chemicals in them, including serotonin and a whole bunch of other chemicals that are involved in forming not only a platelet plug, but initiating the clotting cascade. Describe the events involved in hemostasis. The word hemostasis sounds like homeostasis, but it's different. Hemo means blood. Stasis means controlling. So just like someone who has a bunch of dogs that are jumping all over you, imagine that you've suddenly, you're bleeding everywhere. God forbid, a bullet or a knife or something got you. And you want to control that bleeding. Just like you say, can you control your dogs? They're sniffing me. They're jumping all over me. They're licking me. Well, in this case, you want to control your blood, as in stop it from bleeding. So how do you control your blood? Well, if someone cuts your finger off, God forbid, the blood vessel will spasm. And then there will be what's called a platelet plug forming. And then there will be this thing called blood clotting or coagulation. Now, generally speaking, we like to think this happens first, this happens second, and this happens third. But it's not always like that. Describe three mechanisms, three that contribute to hemostasis. Vascular spasm is only going to happen in an artery or a vein that has smooth muscle along its wall. And the initiation of that can be due to platelets, due to trauma. And then the platelet plug formation, that's another topic. The platelets stick together. Aspirin makes them less sticky. And then the blood coagulation cascade, that's when an inactive chemical, a soluble chemical called fibrinogen, turns into a sticky chemical called fibrin. And there's a whole bunch of steps that have to occur before that, and that's called the coagulation cascade or the clotting cascade. Explain the various factors that promote and inhibit blood clotting. Platelets can release chemicals. They release ADP, serotonin, and that one chemical thromboxane, an eicosanoid. Yes. First, the collagen fibers from damaged endothelium or damaged blood vessels has to be exposed. And when they stick out, the platelets go past them. The collagen fibers cause the platelets to adhere or stick or even rip open. So there's actually the second step called the platelet release reaction. Liberated ADP, serotonin, and thromboxane A2, as you can see being released there, causes something else to happen. And that something else is called platelet aggregation. They suddenly get sticky. They stick to each other, forming a platelet plug, which is not to be confused with fibrinogen turning into fibrin. That's coming up. This is the early stage of fibrinogen turning into fibrin, and you'll notice the red blood cells get caught up in there, and the platelets are obviously helping get in there and stick together, stick to things as well. And this is blood clot formation. This is the intermediate stage, and very soon it will look like this. The late stage showing the red blood cells trapped in the fibrin threads looks like a spider web. And from a distance, you notice this blood clot right there. You can see it with the naked eye. You need a microscope to see the red blood cells, but you do not need a microscope to see a blood clot. This is the Tortora book version of the same thing. This one keeps it a little simpler. It says tissue trauma releases tissue factor, which is also called thromboplastin. And that leads to the common pathway. And on the right side, the intrinsic pathway means that you have something inside of your blood vessel, such as exposed collagen fibers. Exposed collagen fibers will damage the platelets that are passing through. Those poor tender platelets, they get ripped like a balloon that you give to a cat with sharp claws, and it releases chemicals. The platelet does when it rips itself open as it passes through those exposed collagen fibers. Tissue trauma releases tissue factor. Blood vessel trauma exposes collagen, which damages the poor, tender platelets trying to pass through. The platelets release all sorts of chemicals, including phospholipids, calcium, ADP, serotonin, thromboxane, A2, all sorts of chemicals the platelets release, ultimately leading to the same two steps. The last step, which is soluble fibrinogen turning into the insoluble fibrin, and the step right before that, which is prothrombin turning into thrombin. Thrombin is what causes fibrinogen to turn into fibrin. Most abundant clotting protein is numero uno, fibrinogen. The second most common and second most important, let's say, is the prothrombin. So fibrinogen is factor 1, prothrombin is factor 2. Both of these are made by the liver. And in my opinion, the third most important is called tissue factor or thromboplastin. And the fourth most important is called calcium. And it's easy to remember that's factor number 4, ironically, because it has 4 digits. Ca plus plus. Get it? 4 digits? That's factor 4. Man, oh man, you notice calcium is all over the place. Calcium, calcium, calcium. Every place you look, calcium is involved. Calcium, calcium, calcium. Somehow or another, we know that number 1 is fibrinogen, number 2 is prothrombin, number 3 is tissue factor, also called thromboplastin, number 4 is calcium. And then after that, it doesn't get so happy. It gets a little bit more difficult. Most of them are made by the liver. Look at the name of some of these. Anti-hemophilic factor, Christmas factor. Very interesting names. And yes, most of them are made by the liver. This one's made by the liver and the platelets. So there's about 12 of these. There is no factor 6, by the way. So there's 12 of these. And the first one is fibrinogen. That's the most abundant. Prothrombin is the second most abundant. And tissue factor or thromboplastin is released from damaged tissues and activated platelets. So it's released from damaged tissues and activated platelets. Tissue factor or thromboplastin. And then we have calcium ions. Calcium ions are found in the platelets. They're also found in the diet. We eat it, and of course it's found in the bones. But calcium is very important. You got anti-hemophilic factor A. So this one is missing in some people that have hemophilia, where they bleed easily. More common among boys. It's carried by the X chromosome. And this is Christmas factor. Very interesting name. And most of these are made by the liver. Very important. If the liver is an important organ, then what about which vitamin is important for blood clotting? Well, the answer would be vitamin coagulation with a K for clotting. This is needed for normal clot with a K formation because it's used in the synthesis of 4 of those coagulation or clotting factors. Once the clot forms, very interestingly, and this is very important, it retracts or tightens to pull the edges of the damaged vessel together. That is very, very important to know that it exists. So if you get a true-false question, it is true. That's exactly what happens. Another thing is down here, this chemical plasmin. This is another thing you should know, that small unwanted clots are usually dissolved by plasmin, an enzyme that is part of the fibrinolytic system. What in the world is the fibrinolytic system? Your body has a system to make blood clots, but it also has a system to get rid of blood clots. And plasmin is one of the stars of that show. So you should know about plasma. It's an enzyme that is part of the fibrinolytic system that gets rid of unwanted clots. So a quick review here and here. And here. Fibrinolytic system exists. Explain the importance of the classification of blood into blood groups and blood types. These are population groups called European, African, Korean, Japanese, Chinese, and Native Americans. And you'll notice their blood types. You'll notice that Native Americans are mostly blood type O, 79%. The Japanese Americans, their blood type A is more common than blood type O. Usually blood type O is more common, but in Japanese people, blood type A is more common than blood type O. You'll notice that other than African Americans, and especially European Americans, just about everybody else is Rh positive. Korean, Japanese, Chinese, and Native Americans are close to 100% Rh positive. Of the OA, AB, and B blood types, A and O are very common. The least common appears to be AB. AB is the least common blood type. Blood plasma usually contains agglutinins or antibodies that react with A or B antigens. An individual will not have agglutinins against his or her own blood type. Distinguish between the ABO and RH blood groups. For example, I have blood type A. What that means is I have anti-B antibodies in my bloodstream. They don't like blood type B. So I can only receive blood type A. If it's an emergency, I can also receive blood type O as long as it's just the red blood cell. This right here would not be good. This is anti-A. If you gave me blood type B, my body would attack it because my body makes anti-B antibodies. That's ANTI, anti-B antibodies. And what would happen is a agglutination, excuse me, agglutination right there. You see it on the right side? That is not good. I have kind of a funny way of remembering these. First of all, if you have plasma, the plasma would be on top and it would look yellow. So I don't know why they drew the plasma down here, but anyways, let's move on. Think of blood type O like a woman. Let me explain. Imagine ladies' night out. They don't have a mustache, they don't have a beard. This and this are prohibiting men from coming to their ladies' night out. I think of blood type AB as a bunch of welcoming people. You see, blood type AB is called the universal recipient. You can give these people any type of blood as long as it's, the red blood cells. They don't have any antibodies against A or B. So they have mustaches, they have beards, they'll take anything. However, blood type B only has beards and does not want mustaches. They don't want blood type A. So what's blood type A? Blood type A only wants blood type A. They don't want any beards. They don't want any blood type B. That's the way I remember it. I say blood type A is a mustache, blood type B is a beard, blood type AB is a mustache and a beard, and blood type O is ladies' night out. They don't like mustaches or beards. But, ironically, they're the universal donor. Explain why it is so important to match donor and recipient blood types before administering a transfusion. Now, when we say universal donor, we mean blood type O can be given to people with blood type O, people with blood type AB, people with blood type B, or people with blood type A. However, you're only giving the red blood cells. In other words, if you take your test tube and you spin it down, you're only giving the red blood cells, the stuff on the bottom. You're trying to avoid giving the stuff on top, because the stuff on top, as you remember, anti-A and anti-B exists in people that are blood type O. They have antibodies or agglutinins. So as wonderful as blood type as wonderful as blood type O is, it's not good for people with blood type A or B to get their plasma. So it goes without saying that when you get blood, you're only getting the packed red blood cells, the stuff on the bottom, and you're really getting almost nothing else but pure red blood cells. So yeah, the universal recipient is blood type AB, but the universal donor is blood type O, as long as you're giving just the blood. And the two that are, let's say, in between, or, not the best, not the worst, would be blood type A. Because blood type A, you can donate to A, and you can also donate to AB. You see, AB will take anything. And then blood type B, you can only give it to either B or AB. Like I said, blood type AB will take anything. They'll take anything. But blood type O will only take blood type O, even though you can give blood type O to the others. You cannot give blood type A to O. You can't give blood type B to O. You can't give blood type AB to O. But when it comes to blood type AB, if you're sick in the hospital, that's the blood type to get, because there's no restriction. What about me? I'm blood type A. So you cannot give me B, you cannot give me AB. And you can give me blood type A or O. Let's take a deeper look at this. I don't like the way they drew these. Me personally, I would draw this like the letter A, and I would draw this like the letter B, and but anyways, the way they drew it is fine. It's just not the way I would do it. But it just shows you I got blood type A, so what I have is anti-B I've got anti-B antibodies. So don't give me blood type B or AB. The only one you can give me is A or O, as long as you give me this stuff, because I don't want their plasma. I just want their red blood cells. That one you can give to everybody, blood type O. With regard to the Rh blood type, Rh positive, most people are Rh positive, but a lot of people are Rh negative, and that could be an issue. We don't normally, if you're Rh negative anyways, we don't normally worry about Rh positive blood, but sometimes it gets in you. How's that? Well, let me tell you. If you get the wrong blood type, by the way, this is what could happen. This is the problem. Besides the Rh issue, if you get the wrong blood type, you could basically form these little clumps, and that could diminish blood flow to the smaller blood vessels. If this is the donor blood type and this is the recipient blood type, what they can do is take a little bit of the donor blood and mix it with your blood. And if there happens to be a clumping reaction, then they will not give you this blood. If there is no clumping, then they will give you the blood. So they actually do this test before they give you the blood. This is called a glutination, where it's like handcuffing these together. So if you get the wrong blood type, this could happen, a glutination. And this goes back to what I was saying earlier. These blood type O people are welcome everywhere. Blood type O. They don't have the mustache or the beard. But their plasma has anti-A and anti-B. So they don't like blood type A or B. And blood type AB, this is called the universal recipient. This one, because you can give them any type of blood. This is called the universal donor, because you can give this to anyone. One more time. Blood type AB is the universal recipient. They'll take anything. Blood type O is the universal donor. You can give to anyone, but not their plasma. Their plasma is not so nasty, but it is not so good, I should say, because it's got anti-B and anti-A. Blood is stored in a refrigerator and it's cold. I've got blood type A, which means my blood cells here are blood type A. What I have in my plasma is an antibody, which is called antibody against B. So it will attach to and attack blood type B. It will destroy blood type B. So I'm blood type A, which means I've got the A protein, and then I've got the antigen against B. I don't like blood type B because I'm blood type A. Get it? By the way, if you receive one packed red blood cell unit, it will raise the hematocrit of a standard adult patient by about 3%. So if your hematocrit is supposed to be, let's say, 45%, and it is down to, I don't know, let's say 22%, then if you get a packed red blood cell unit, you'll be up to 25%, and if you get another one, you'll be very close to 30%, which is not so bad, but still kind of low for most people. Women are usually a little below 45%. By the way, how do you determine the percentage? You simply look at the height of this, and then you look at the height of this. So let's say this is 4 centimeters, and then this is, let's say, I don't know, 9 centimeters. You basically take 4 divided by 9. Actually, this looks more like 5. Let's say 5. 5 divided by 9, and this would be well over 50%. So this would be unusually high for a female, and it could be normal for a male, especially a smoking young male. Because believe it or not, people that live on top of a mountain or they smoke, they make a little bit extra red blood cells, believe it or not. Packed red blood cells is what you receive when you receive a blood transfusion. You do not get the plasma usually. In the hospital, they say type and cross-match 1 unit of blood, type and cross-match 2 units of blood. Type and cross-matching, these are performed in order to determine the blood type. A drop of blood is mixed with the anti-serum that will agglutinate blood cells that possess the agglutinogens that react with it. In other words, they will clump up the blood cell that possesses the antigens. And this is a lab that we normally do. This is person number 1. This is what their blood looks like. You treat them with anti-A serum and you see clumping. You treat them with anti-B serum, you see no clumping. So you have 3 drops of their blood, and the only one that clumped is the A, so they're blood type A. In this one, the only one that clumped is the B, so it's blood type B. You see, if nothing clumps up, that means they probably have blood type O, because there's nothing to grab, so to speak. There's no mustache, there's no beard, so this one ends up being type O. If both of them clump up, then it's blood type AB. And we have to remind ourselves of the word agglutination. It's not called clump up, it's called agglutinate, but that's okay. So here's a blood sample, and here is the blood sample, and here is the blood sample from the same person. You add anti-A here, nothing happens. You add anti-B here, nothing happens, so it's blood type O. This person's blood, a different person, you put the blood here, you put the blood here and add the anti-A and it clumps up. You put the blood here, you add the anti-B and it clumps up. That means they are A and B, which means AB. Just a quick reminder, this column is what the blood would look like if you just don't treat it at all. This column has anti-A, which would be obtained from a person with blood type B. This blood type A people would be making this. In other words, I've got blood type A, which means I naturally make anti-B, if you know what I mean, because my body doesn't like blood type B. Describe the homeostatic imbalances that affect blood. There are dozens, hundreds of blood problems out there, one of which is hemolytic disease of the newborn. This is the one I mentioned earlier, where a small amount of the fetal blood leaks into the mother, the pregnant woman's circulation. If the baby is Rh positive, thanks to dad, and the mother is Rh negative, she, the mother, will develop antibodies to that Rh factor. During that pregnancy, and especially during the next pregnancy, with an Rh positive baby, she transfers antibodies to the fetus. And those transferred antibodies will attack the fetus's red blood cells, causing agglutination and hemolysis. Hemolytic disease of the newborn. In the first pregnancy, a little bit of the baby's blood gets into the mother around childbirth, or maybe before childbirth. And between pregnancies, or at the end of that pregnancy, she will make anti-Rh antibodies. With the second pregnancy, those anti-Rh antibodies will attack the baby's blood cells. Not good. And that's why we have RhoGAM injections. These are given after the woman has the baby, and even before she has the baby, they give this injection. And what it does is it causes her immune system to kill or clean out the Rh protein before her immune system has a chance to really react to it. I call it like someone broke into your garage, you call the police, and then you realize no one broke in. So you call the police back, you say, "Oh, never mind, we just left the door open, there's nobody there." The RhoGAM helps you so your immune system does not get involved. Otherwise, yeah, with the second pregnancy, it would be bad. Now let's learn about the heart, the physiology and anatomy of it, the cardiac cycle, and what makes it speed up or slow down. Let's study that. Main learning objectives for the heart. Describe the position and structure of the heart. The heart is located between the lungs in an area known as the mediastinum. Describe the location of the heart. Located just superior to the heart itself are the great vessels, and in the superior mediastinum you also have the trachea, some lymph nodes, the esophagus, and the superior vena cava, which is the superior vena cava, which is bringing blood down from the head and shoulders. Describe the structure of the pericardium and the heart wall. Imagine your fist as the heart, and you put your fist inside of a water balloon. That is basically the idea of the pericardium, and the outer part of the part that seems to be painted on the heart, or for example stuck right on it, is the visceral pericardium. And then there's fluid outside of that, a lubricant known as serous or pericardial fluid. And then the outer part of the bag is called the parietal pericardium, the serous part. And just outside of the serous part, it turns into what is known as the fibrous pericardium, which is more on the outside of the two layers of the inner serous. VP, Vice President, VP. Discuss the external and internal anatomy of the chambers of the heart. And you can look at the Unit 2 anatomy list. It has all the little parts named. For example, mitral valve is called bicuspid valve or left atrioventricular valve. The cordae tendineae are sometimes called tendinous cords or even heart strings. The raw PowerPoint, you can click this and look at cardiac muscle. The tissue of the muscle of the heart is the myocardium. The epicardium is the previously mentioned visceral layer of the serous pericardium. It changes names to epicardium. The endocardium is more or less the endothelium, or the inner thin epithelial cells which line the inner layer of the heart, which touches the blood passing through. You can see here the inner layer is not labeled, but the outer layer is the fibrous pericardium, and then the parietal layer of the serous pericardium, and then the deepest layer there or deeper layer is the visceral layer of the serous pericardium, also called epicardium. And then the rest of it going inwards is myocardium, and all the way on the inside touching the blood passing through the endocardium. Here you could see evidence of the fibrous pericardium up there, and there's also a fibrous pericardium down here, holding the heart down to the diaphragm, locking it down. That would be called the fibrous pericardium. The chambers of the heart include the upper two chambers and the lower two ventricles. The upper two chambers are collecting chambers, and they're called atria. The blood from the superior vena cava and the inferior vena cava go into what's known as the right atrium. The blood from the lungs goes into what is known as the left atrium, which would be the upper chamber on the patient's left. The word auricle means ear, and just like a dog ear, there's an auricle, a little extension of the atrium, embryologically distinct, but yet physiologically part of the atrium in that it can expand. If there's ever an increase in blood flow, you're chasing a bus, running, the auricles can help increase the size of the collection chamber known as the atrium by being a secret extra place to expand. It's usually covered with some fatty material. Off the arch of the aorta, there's 3 blood vessels you should know, and this third one is called the left subclavian vein. The second one is called the left common carotid artery, and the carotid arteries themselves that are common, they will split into an internal and an external on the left and on the right. The number 2 and 3 are coming off of number 1 for the right side of the body. So whereas the number 2 and 3 come off the aorta separately, in human beings usually the right subclavian and right common carotid artery come off of this number 1, which is called the brachiocephalic arterial trunk. You should also know this structure, which is really no longer a blood vessel. It's called a ligamentum arteriosum. Before we're born, it's called the ductus arteriosus, and it allows the blood to go from the pulmonary arterial trunk into the aorta, because in fetuses there's no reason to send all that blood to the lung because they're under amniotic fluid, water, and so the left and right sides of the heart seem to work together to pump blood into the aorta, which leads to the baby's placenta, the fetus's placenta, let's say. And here you see the right auricle, and there's the brachiocephalic trunk. The magical name is BAT, brachiocephalic arterial trunk. I call it the BAT. And here you can see the superior vena cava and some other structures. Down this indentation known as the anterior interventricular sulcus runs the left coronary artery branch known as the LAD, or the anterior interventricular artery. Left anterior descending artery is another name for it. The blood in the aorta not only goes up to the head, but it also gives off several branches, and of course gives off branches that go to the legs and the abdomen. So deep to this area would be the right ventricle, and over on this side this would be the left ventricle, and it's the left ventricle that actually pumps into the aorta. So that's a little confusing. It's kind of crisscrossed. The right one pumps this way and the left one pumps that way. I kind of like this slide because it actually shows us 2 branches of the left coronary artery. One of them running down the anterior interventricular sulcus, and the other one just lateral to it on the left side. And this is more like real life. And you can see the right coronary artery here, which often gives off branches that go this way. And the most prominent one in our book is called the marginal branch. And this is a posterior view, you can see the coronary sinus dumping into the right atrium, along with the superior vena cava and the inferior vena cava. Those three things dump into the right atrium right there. Right atrium receives blood from the superior and inferior vena cava and the coronary sinus. Relate the thickness of the chambers of the heart to their functions. Right ventricle receives blood from the right atrium like this, and then it sends blood up and over to the lungs through the pulmonary arteries, pulmonary arterial trunk at first, which splits. So these blood vessels here would be sending blood to the various parts of the lung. Which lung? The right lung, because you're looking at the person. The blood from the lungs goes over to the left atrium, which is right here. This is the left atrium, and then the blood goes down through the mitral valve, also known as the bicuspid valve, into the very large left ventricle. And then the left ventricle will pump the blood into the aorta through a valve that you can't really see here. It's barely visible. There it is. Goes through that valve right there. The left ventricle has a tough job to do, and that's why it is much thicker. Did you notice that? Left ventricle, myocardium of the left ventricle, much thicker than the myocardium of the right ventricle. And of course, they share that septum. The shared area here is called the interventricular septum, just like the septum between our nostrils. The fibrous skeleton of the heart serves to prevent overstretching of the heart valves. It forms the foundation for which the heart valves attach. And the fibrous skeleton acts as an electrical insulator as well as a point of insertion for cardiac muscle bundles. So the heart underneath it has some collagen fibers and other fibers that keep it strong. Describe the valves of the heart and the circulation of blood. I personally call the valves preventricular and postventricular. The one after the ventricles are the pulmonic and aortic valves, and I call those postventricular. They're called semilunar. The others are called AV or atrioventricular because they're between the atrium and the ventricle. I call these preventricular valves. So my language is pre and post, left and right. This is what the valves look like when they're closed, and this is what they look like when they're open as far as the AV valves. The other valves look more like this when they're closed. They don't have any strings on them. They don't have any cordia tendineae on them. No heartstrings or tendinous cords. The semilunar valves usually are like about 3 pieces like that. Describe the structure and function of the valves of the heart. You can take another look here. Usually when these are closed, it's because the heart is filling. The ventricle is filling. Once the ventricle fills, these snap shut, give you the first heart sound, and then of course the blood would be gushing out of the aorta and or the pulmonary valve, pulmonic valve. And then once it's done coming out, then it snaps shut and it gives you the second heart sound. And of course, then these guys open. So they open and close. So it's boom, boom, brum, 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 brum. And between the first and second heart sounds, the blood is gushing out of the ventricles. So if you could almost hear it, it's like boom, 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 and it empties and fills, empties and fills. Outline the flow of blood through the chambers of the heart and through the systemic and pulmonary circulations. Again, you can see the Unit 2 anatomy list for the names of those blood vessels, such as aorta, brachiocephalic arterial trunk, axillary artery, etc. The heart seems to be two separate pumps, one which receives blood and sends it to the lungs, and the other which receives blood and sends it to the body. The vena cava dump into the atrium, and the atrium pushes the blood into the ventricles and allows the blood to go into the ventricles. The ventricles pump the blood out. From the lungs, the blood goes into the left atrium, left ventricle, and then out the aorta to the head, shoulders, to the body, to the legs. Once the blood goes through the capillaries, that means it's gone through the tissues of the body. Then it will come back in small veins called venules, which join and form larger veins called, well, veins. Really thick, gigantic vein is this one, which is called the inferior vena cava. Discuss the coronary circulation. Not too many to know here. Coronary arteries deliver blood to the myocardium. The coronary veins deliver that blood that has gone through the heart back to the right atrium. So the blue ones, such as the anterior cardiac vein right there, that blue one, and this blood vessel that's feeding the great cardiac vein up here, these are spent blood. The red ones are fresh blood. The red is delivering blood to the heart from the aorta, for example, this direction, like that. And then the blue one is returning blood to the heart. This is a great image and shows you the circulations separated. Here you see the arteries, coronary arteries and their branches, and here you see the coronary veins. The funny thing is, cardiac veins. All of the veins are called cardiac veins, except for the biggest vein, which is called the coronary sinus. So the word coronary is used for two of the arteries, the left coronary artery and the right coronary artery. And it's used for one of the veins, that vein being, of course, the coronary sinus. You should know the marginal branch of the right coronary artery and the right coronary artery itself. You should know the left coronary artery, the circumflex branch, and the anterior interventricular artery, or LAD, left anterior interventricular artery. It's actually called anterior interventricular artery or left anterior descending artery, LAD. So it's either called LAD, left anterior descending artery, or anterior interventricular branch of the left coronary artery. It splits, it branches. Now there's more than one marginal branch, but we're pretending like there's only one. And for the veins, this right here is the most important vein. The other ones are kind of hard to learn. You have the small cardiac vein, the anterior cardiac vein, middle cardiac vein, and the great cardiac vein, but it's the coronary sinus that seems to be the most important, the last stop before it dumps into the right atrium. Describe the structure and function of cardiac muscle tissue and the cardiac conduction system. Cardiac muscle tissue features intercalated discs. But what are intercalated discs? Intercalated discs feature gap junctions, which are tiny little holes that allow the fluid from one cell to go into the next cell. We're talking about electrolytes. And desmosomes. Desmosomes are kind of like little ropes. They tie the cells together. These are the gap junctions. And those represent the desmosomes.
These gap junctions right here, they allow sodium and other electrolytes to go from one to the other cell, causing the heart to be a functional syncytium. So they share fluids here. This is the intercalated disc featuring desmosomes and the gap junctions. The gap junctions are these things, and the desmosomes are these rope things, basically holding them together physically.
Another thing that sets the cardiac muscle cells apart is they're self-excitable or autorhythmic. Instead of a neuron waiting to be provoked or lose its temper, waiting for the doorbell to ring to trigger the sound, triggered window opening or heater going on inside of the house, these cells seem to lose their temper simply because of the whistling of the wind through the cracks in the window. They don't need a doorbell. Yes, they repeatedly generate every second or so in adults spontaneous action potentials due to what's called the leakage. This pacemaker potential is nothing more than leakage of sodium into the cell. Sodium leaks into the cell, triggering at this point sodium voltage gated channels to open. The sodium voltage gated channels then close here. The potassium voltage gated channels open at that point, and then they close down here and the leakage continues. So you could look at it as really about 3 or 4 things happening. The fourth one is the 24-hour-a-day, 7-day-a-week sodium potassium ATPase pump that has to be working all day. Now, I can describe this using the analogy of someone sleeping in their house, and they have a garage door, they have windows, they have a heater on, and it's the middle of winter. But basically, to keep it simple, what's happening is it's constantly losing its temper, and that's a good thing because it keeps the heart beating. Describe the structural and functional characteristics of cardiac muscle tissue and the cardiac conduction system. Well, like I said, this is the sound of the wind howling, and it reaches a certain point. Then it triggers something to happen, and that something is sodium pouring in locally. Then it stops. Then the potassium comes out, and that stops. And then, lo and behold, instead of like a normal neuron, the cell resting, instead of resting, it continues to be slightly provoked. until it fires again, roughly speaking, every second or so. And that leakage is called the pacemaker potential. It's like someone that naturally loses their temper every so often. Explain how an action potential occurs in cardiac contractile fibers. Just like someone who loses their temper every so often can lose it a little quicker with some provocation, things like adrenaline, extra thyroid hormone, hunger, electrolyte imbalances, caffeine, nicotine can speed this up a little bit so it happens a little faster. And things like sleep and relaxation and other things can slow it down so that your heart actually slows down. And all the details of what happens in my analogy of someone sleeping in their house and the wind howling, I can go over that if you're interested, if it helps you understand it. But basically, that's it. Describe the electrical events of a normal electrocardiogram, or EKG. Now, those provocable cells we were talking about are largely located in this sinoatrial node, and some of them are also in the AV node. Some of them are hiding here and there. This is, by the way, the AV node right in here. In other words, the main pacemaker is right here, and then the other pacemaker that's in some ways more important is right here, the one that turns the ventricles on. And then there are occasionally other places that could become pacemaker cells. But we don't want those to fire. We want them to remain dormant. We want the heart to beat in an organized way so that it can function. This shows you what happens in the heart when it comes to basically squeezing. The depolarization causes the muscle to contract. And then there's this thing called repolarization that happens just a little bit later so that it will be able to contract again. In the heart, cardiac muscle generates ATP via anaerobic cellular respiration and creatine phosphate, which is called CP. When you look at the heart in general, you can actually see a small P wave with an EKG. That represents the electrical activity passing the atria. That's called atrial depolarization. This QRS represents ventricular depolarization. This T represents ventricular repolarization. And if you're wondering where is atrial repolarization, well, it's buried in the much larger QRS, so you don't really see it. So the atria and ventricles take turns depolarizing and repolarizing, but you can only see the ventricles repolarization. An EKG is a recording of the electrical changes that accompany each heartbeat as millions of cells contribute to it as that wave of electricity passes through all those cells. Over and over again. And when the shape of this is unusual, sometimes it's a sign of a disease that is sometimes treatable or preventable. Action potential propagates through the heart. You see the P wave. The atria begins to contract right after that. And the QRS right after that is the ventricle contracting. In other words, we're looking at the electrical activity passing through, which is accompanied by an almost immediate muscular reaction. And this T wave is repolarization, where the muscle goes back to the way it was before. And it's ready to do it all over again. When the ventricle is filling with blood, it's called diastole. It's called the relaxation phase, when it's filling with blood. Describe the events of the cardiac cycle. So I've been mentioning electrical events leading to mechanical events. But what happens is the electrical event causes contraction, which causes the pressure to go up. And then when the valves snap shut, that gives you a heart sound. And the volumes are going up and down, up and down. When it's contracting, it's called systole. When it's relaxing and filling, it's called diastole. Of the ventricles and the atria, they take turns filling and emptying, filling and emptying. These are the electrical events. One more time. Atrial systole happens right after the P wave. Ventricular systole happens right after the QRS. And of course, the T wave represents the electrical activity going back to normal, and that's about the time that the ventricle is passively refilling up. Describe the pressure and volume changes that occur during a cardiac cycle. So probably the most exciting thing here is when the ventricle is squeezing. Yes, that's when the ventricle is pushing blood out of the aorta, and you will notice that is basically when the blood is leaving the ventricle. And the funny thing is, you'll notice the first heart sound, and then you'll notice the second heart sound. And it's between the first and the second heart sound that the ventricle is emptying. In other words, between the first and the second boom, 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 boom. That V right there is between the first and second boom. So that's when the ventricle is emptying. If you could hear the blood leaving, it would sound like this. The first heart sound is called S1 and then S2. Now technically there's two valves closing in S1, and those are the two AV valves, the preventricular valves. The postventricular valves, known as the aortic and pulmonary, or aortic and pulmonic, those close, giving us the second heart sound. And these are the listening posts. You'll notice that the mitral listening post is over here, the aortic listening post is over here, and then the pulmonic listening post is over here, and the tricuspid listening post is right about here. That's the best place to hear the valves if they're making a noise. And these are interesting to look at. You'll notice how the volume obviously decreases from about 125 to around 50 or so, which means about 75 milliliters gets kicked out, or in this case it looks about like 70 milliliters gets pushed out. Relate the timing of heart sounds to the EKG waves and pressure changes during systole and diastole. And this is showing us the EKG and how it's related to all these noises and flows and pressure changes. So it's kind of cool to match all these up. Describe the factors involved in the regulation of cardiac output and heart rate. Cardiac output is the volume of blood ejected from the left or right ventricle into the aorta or pulmonary trunk each minute, and this is the way you calculate it. Cardiac output is equal to the stroke volume times the heartbeat, the pulse. Define cardiac output. You can click this and watch this if you have the PowerPoint, which I uploaded. Outline the factors that affect the regulation of heart rate. All these factors can help regulate heart rate. You can look at this from the chemical to the societal level.
Some marathon runners have a heart rate below 50, like 48 at rest, maybe even 46. Epinephrine, adrenaline, hormones of pregnancy, thyroid hormone, these can change your heart rate. Having people outside your house that are threatening you could also make you nervous. Temperature, all these things can affect the rate of your heart. Potassium or sodium being way off, calcium. Input to the cardiovascular center of the brain, output to the heart. The vagus nerve is stimulated by eating. You can also slow your heart down with going to the bathroom, defecating, urinating, a rectal exam, rubbing your eyes. Some people talk about breathing patterns affecting your heart rate. What is measured is the pressure of your blood, the chemistry of your blood, movements, such as if someone pushes you and you get dizzy all of a sudden, or your car suddenly stops, the limbic system, the smell of a burning fire in the kitchen. Something burning in the kitchen would make you breathe differently. A cat smelling catnip. The hypothalamus and the cerebral cortex are interpreting things, determining whether it's a threat or not. And they can directly stimulate the heart to beat faster and contract more vigorously. Explain how the heart is affected by exercise. Anything that increases heart rate or stroke volume will increase cardiac output. Stroke volume seems to go up if the afterload decreases, which is what the heart has to pump into. In other words, if your arteries that your heart has to pump into are easy for the blood to pass through, or if there's something causing your heart to contract more strongly, such as increasing the amount of blood flowing into it within limits, that is called Frank Starling law, the idea that cardiac muscle fibers contract more forcefully with stretching. Heart rate can be increased and is naturally higher in infants, senior citizens, females, people that are out of shape, and people that have a fever. Heart rate can go up due to chemicals, drugs, thyroid hormone, adrenaline, or epinephrine, or a perceived threat. And your body is measuring chemicals, blood pressure, and smells. If the kitchen is burning, for example, that could stimulate your heart to beat faster. Describe disorders that affect the heart. Well, here are the headlines: coronary artery disease, arrhythmia, heart valve problems, congenital heart disease, problems with the heart muscle, and heart failure. Arrhythmias are electrical rhythm disturbances. Coronary arteries can become diseased or clogged.
Homeostatic imbalances. Well, guess what? Some pills for heartburn, those over-the-counter H2 blockers and hydrogen ion pump inhibitors, well, guess what? They can cause dysrhythmias or arrhythmias. All right, now let's do a musical tour through some of these images using this book's images. Artery away, vein toward the heart, capillaries to the body tissues, north of the lung. Get blood vessels now. Describe the relationships among the different blood vessels and the movement of blood through them. Arteries carry blood away from the heart to the lung tissue or the body tissue through capillaries, eventually. The walls of the arteries are elastic, which allows them to absorb some of that pressure that the ventricular contraction is causing. Because of the smooth muscle in the tunica media, the arteries can actually open and close, widen, vasodilate, and shrink, vasoconstrict. There are at least a couple of types of arteries based on structure. One is elastic, and one is called muscular or distributing arteries. The elastic ones are also called conducting arteries. So this happens to be alphabetical. E goes with C, or E goes with M, and C goes with D. So the muscular arteries are helping distribute the blood. The elastic arteries are conducting it from the heart to the muscular arteries. Here you can see the aorta acting as a pressure reservoir, basically stretching and bouncing back to shape with every heartbeat and every relaxation. The word they use here is recoil. They stretch and then they go back to the way they were. Anastomosis, plural anastomosis, or anastomoses in Chicago speak. An anastomosis is the union of the branches of two or more arteries supplying the same region. This provides an alternate route or an alternate route for blood flow. Arteries that do not form an anastomosis are called end arteries. If an end artery is blocked, blood would not be able to get to that particular region of the body, and necrosis would occur. This is showing capillaries close up. Don't be scared now. Look at that. Look at that red blood cell leaking out of a capillary. And those are red blood cells passing through. That's Oprah, by the way. Those are the red blood cells passing through. Okay, that wasn't, I don't know. If you have the PowerPoint, I recommend you click these and look at these. Great way to study.
Capillaries connect arterioles to venules.
Contrast the structure and function of arteries, arterioles, capillaries, venules, and veins. Look at blood flow through the capillaries. This right here is a capillary, okay, right here. And these things over here, the one that says meta-arteriole, it literally means that which is beyond the arteriole. And the reason that this area down here is called a post-capillary venule is because it's not a capillary anymore, and it's not a typical venule, which has muscles. This post-capillary venule doesn't have muscle along its wall. I want you to look at these precapillary sphincters here. These open and close every 8 seconds or so, or 10 seconds in some parts of our body. It's called vasomotion. They open and close, taking turns. And what vasomotion means that these capillaries receive blood for a few seconds and then they no longer receive blood. These are the main capillaries underneath your skin when you get a paper cut. These are the fenestrated capillaries. You would find these, for example, in your kidney, producing urine, and in other places producing special fluids like the fluid in your eye or cerebrospinal fluid. Notice all the little fenestrations or pores in there. Imagine putting water in your mouth with some apple juice and cherries, and then you go like that. What comes out is the apple juice, the water. These are sinusoidal capillaries. These are found in the spleen and the liver. And on the other side of these, there might be white blood cells that reach in and pull out the old red blood cells for destruction. For example, these are found in the bone marrow as well, this type of capillary. So it's C, F, and S, sinusoidal, fenestrated, and continuous capillaries. Those are the three types. Vanules are the little veins that form when the capillaries are done with their thing. The venules lead to the veins. The veins don't have as much of a tunica media or a tunica interna. However, they have a very large lumen and they feature valves. And most of the blood is in our veins and venules, believe it or not. It's sort of a slow flow, large volume pipe. Now we should look at the vessels through which blood moves in its passage from the heart to the capillaries and back one more time. And you should know that the aorta is an elastic artery, the radial artery is a muscular artery. They're also known as distributing arteries. And the elastic arteries are also called conducting arteries. You should also know that the arterioles are the small arteries, and then the capillaries are receiving their blood from the arterioles and permitting the exchange of nutrients and wastes between the blood and the interstitial fluid of the body tissues. They send their blood to the postcapillary venules. The, the postcapillary venules are basically not muscular, and the muscular venules do have a little bit of muscle. They pass the blood into the veins. The veins don't have an internal elastic lamina like the arteries do. They basically return the blood to the heart, and they have valves. And they're much thinner than the arteries, but they are much larger as far as their lumen. Most of the blood is in our veins and venules. The systemic veins and venules are basically the blood reservoir. The pressure reservoir could be thought of as the aorta, for example, which bounces back and forth. But the reservoir for blood, it's the veins. Explain the factors that regulate the volume of blood flow. As blood is pumped out of the left ventricle into the elastic aorta and the distributing arteries, known as the muscular arteries, pressure is generated. The mean or average arterial pressure is determined by the cardiac output, how much blood, how much liquid is pumped out per minute, and also by the systemic vascular resistance, how loose or how tight, how wide, how narrow are those pipes. The central venous pressure also matters a little bit. The veins are usually pretty low resistance, and they have valves to prevent backflow. So roughly speaking, you can almost ignore that, but according to the following relationship, which is based upon the relationship between flow, pressure, and resistance, blood flow, right here, blood flow is the volume of blood that flows through any tissue in any given time period in milliliters per minute. That cardiac output is definitely milliliters per minute. The total blood flow is cardiac output, the volume of blood that circulates through the systemic or pulmonary blood vessels each minute. The systemic vascular resistance, if that goes up, that makes the job much harder, and that makes the mean arterial pressure higher. So if your cardiac output is really good and your systemic vascular resistance is really low, your mean arterial pressure will be just fine. This central venous pressure is usually negligible. You can laugh at it. And if you click this link, you'll learn a lot more. Explain how blood pressure changes throughout the cardiovascular system. The contraction of the ventricles generates the blood pressure. Blood pressure is determined by the cardiac output, how much blood you actually have, and the vascular resistance, how tight, how small, how constricted or dilated and wide are the blood vessels. The higher the blood pressure, the greater the blood flow usually. And if you think about this, the thickness of the blood matters a little bit too. That's called viscosity. This is showing the fact that in the arteries and the aorta and the arterioles, blood pressure goes up and down, up and down, up and down. This little notch here is thanks to the aorta, believe it or not, bouncing, recoiling, let's say. In other words, that little jump in pressure right there is due to the aorta bouncing back or recoiling. Anyways, you'll notice in the venules and the veins and the vena cava, the blood pressure is very, very low. But most of the blood is actually here. So I call the arteries jet wash because it's like, psht, blowing the blood. And then the veins are more like a slow, slow river. Describe the factors that determine mean arterial pressure and systemic vascular resistance. Blood pressure is determined by taking the systolic blood pressure and adding it to the diastolic blood pressure and adding it to the diastolic blood pressure again and dividing it by 3. In other words, if your blood pressure is 100 over 70, then it would be 100 plus 70 plus 70 divided by 3. So that would be, let's see, 240 divided by 3, so that would be 80, which is a decent number. If the mean arterial pressure is below 70 or below 60 or below 50, it gets more and more serious because We need a mean arterial blood pressure to be at least around 60 or 70 to perfuse the tissues of our body. Otherwise, we would fall into what's called shock. If you click this, you'll learn more about it. The vascular resistance, this is the opposition to blood flow due to friction between the blood and the walls of the blood vessels. The higher the R, the smaller the blood flow. R depends on blood viscosity, like I mentioned, but also the total blood vessel length, and also the size of the blood vessel lumen, how wide the pipes are. Venous return, the volume of blood flowing back to the heart through the systemic veins, occurs due to the pressure generated by contractions of the heart's left ventricle. The venous return is assisted by valves, respiratory pump, and the skeletal muscle pump. This demonstrates the skeletal muscle pump. You notice there's a valve here and a valve here, so if the muscle squeezes, the blood has no choice. It can't go backward, so it ends up getting propelled forward, and that's called the skeletal muscle pump. Describe the relationship between cross-sectional area and velocity of blood flow. Blood flow is inversely related to the cross-sectional area of blood vessels. In other words, if you have a given pressure, you put it through a jet wash, the water will spew out quickly. But if you open up the hose, then it will come out more slowly, as if. But the amount of liquid coming out would be the same. But in one case, it would be coming out quickly through a small opening, and in another case, it would be coming out slowly through a large opening. Blood flow is the volume of blood that flows through a tissue in a given period of time. You'll notice that in the aorta, the velocity is high. In the capillaries, the velocity is low. However, the cross-sectional area is very high. These are places you can check your pulse. The superficial temporal artery is medial to the ear. The femoral artery is just inferior to the inguinal ligament. The popliteal artery is difficult to palpate for me. It's posterior to the knee. The radial artery is easy. It's lateral to the ulnar artery, which is also palpable but with more difficulty. The dorsalis pedis artery of the foot is superior to the instep of the foot. It's not far from the bones that are at the base of the big toe. And we'll look at pictures of these in just a minute. The brachial artery is often the place where blood pressure is checked, and the common carotid artery is in the neck. If you reach under your biceps brachii, right now you can feel the brachial artery. You can palpate the radial artery here. The ulnar artery is more difficult. The common carotid artery is in the neck. The superficial temporal is just on the side of the head here near the temples. The femoral artery is located halfway between the genitals and the anterior superior iliac spine. So it would be right about here. The illustration is a little bit off. The popliteal would be behind the knee. The dorsalis pedis would be just on top of the foot. And then there's another one right behind the medial malleolus. It's called the posterior tibial. Define pulse, systolic, diastolic, and blood pressures, pulse pressures. The systolic blood pressure is the upper number, for example, 120 millimeters of mercury. The diastolic blood pressure is the lower number, let's say 80 millimeters of mercury. This is a future topic, so we're going to come back and look at this topic in the near future. So don't worry about it right now. We will look at it again in the future. Describe the body's attempt to restore homeostasis in response to shock. What is shock? What are 4 types of shock? Shock is an inadequate cardiac output that fails to meet the metabolic demands of body cells. The body is just not being perfused with blood. Cell membrane function can go downhill. Cell metabolism slows down. The cells can die. The book mentions hypovolemic shock, where you don't have enough blood, not enough fluid. Could be from dehydration, hemorrhage, blood loss, blood donation. Cardiogenic shock is due to something wrong with the pump, whether it's a valve, whether it's a heart attack, congestive heart failure, whether it is a bullet in the heart, whether it's bleeding around the heart in the pericardial sac called pericardial tamponade, whether it's an arrhythmia or dysrhythmia due to all those pills people take for heartburn, which is a big scam. Cardiogenic shock can occur, and death. Vascular shock due to something wrong with the blood vessel. Maybe it's closed, for example. Obstructive, something obstructing the blood vessel. Now, vascular shock, to me, I think of septic shock because the blood vessels dilate, and there's also blood clots. And then there's anaphylactic shock, bee stings, allergies, neural shock, a bullet to the brain, or a gigantic stroke. These are all different types of shock that will lower your blood pressure. I found this chart on the internet, and it mentions anaphylactic shock and septic shock, cardiogenic shock. A lot of these are interchangeable in some ways. Basically, is the cause the heart? Is the cause an allergy? Is the cause an infection? Is the cause brain damage? These are all questions to ask when someone's blood pressure is very low. Is it hemorrhage? I don't see the word hemorrhagic shock here, so I have my own way of doing this, and I probably should have made my own list, but that's okay. Let's move on. Explain how the body's response to shock is regulated by negative feedback. Well, basically, if someone's in shock, the body is going to respond by releasing all these hormones and stimulating the sympathetic nervous system and releasing what are called vasodilators to bring more blood into that area. Of course, what that ends up doing is dropping the overall pressure. The quick response is a nerve response. The slow response is a kidney or hormonal response. The quick response will result in a heart beating faster, blood vessels tightening up, and then urinating less, and there will be responses that include hormones going up that save sodium. Aldosterone saves sodium. And then hopefully that will return everything back to normal. And once everything goes back to normal, then we are back in balance. Signs and symptoms of shock: clammy, cool, pale skin, fast heart rate, weak, rapid pulse, hypotension, systolic blood pressure below 90, sweating, altered mental status, decreased urinary output, thirst, and acidosis. When I had food poisoning, my blood pressure was 82 over 58 with a pulse of something like 118. Mind you, back then my pulse was normally around 50. So this was double my normal pulse with a blood pressure that was pretty low after I had food poisoning. I had the Atlantic Ocean and the Pacific Ocean. I had vomiting and something else. Yeah, so by the time I went to the emergency room, they gave me 4 liters of IV fluid, one after another, and then let me go home. That's a lot of IV fluid. But that was one big food poisoning. Circulatory routes: systemic circulation, pulmonary circulation, hepatic portal circulation, and fetal circulation. Let's briefly look at these. The systemic circulation goes to and from the arms and legs. The hepatic circulation is going to this thing known as the liver. And you'll notice the liver has a vein feeding it, but it also has an artery feeding it. So it's kind of unusual. Define systemic circulation and explain its importance. The systemic circulation is feeding blood to the body systems. And this includes our legs. You'll notice here that the aorta splits into a common iliac artery on the left and the right. Then it gives off this branch called the internal iliac. What's left is the external iliac, and the external iliac artery on the left and right turns into the femoral artery once it passes this inguinal ligament here. Once it passes that ligament. And all of these blood vessels we've been talking about come off the abdominal aorta. Another blood vessel that comes off the abdominal aorta is the superior mesenteric artery and the inferior mesenteric artery, I and S. Also, the renal arteries that feed the kidneys and the gonadal arteries which feed the ovaries or testes. Describe the 4 principal aortic divisions and the arterial branches that arise from each. Well, for the aorta, we have the ascending aorta. Then we have the arch of the aorta. Then we have the descending abdominal aorta, actually the descending thoracic aorta. And then we have the abdominal aorta, which is the lowest aorta. Identify 4 principal divisions of the aorta. Well, we have the ascending aorta, the arch of the aorta, and the thoracic and abdominal aortas. It's the same aorta, of course. Locate the major arterial branches arising from each division. From the ascending aorta come the two coronary arteries, left coronary artery, right coronary artery. From the arch of the aorta comes the brachiocephalic trunk, as well as the left common carotid artery and the left subclavian artery. Identify two primary arterial branches of the ascending aorta. Well, the right coronary artery and the left coronary artery are the two main branches. Identify the three principal arteries that branch from the arch of the aorta. We have the brachiocephalic arterial trunk, the left common carotid artery, and this is the thoracic aorta.
You are the woman that I've always dreamed of. I knew it from the start. I saw your face and that's the last I've seen of my heart. It's not so much the things you say to me, it's not the things you do, it's how I feel each time you're close to me that keeps me close to you. Oh, you are the woman that I've always dreamed of. I knew it from the start. I saw your face and that's the last I've seen of my heart. It's not so much your pretty face I see, it's not the clothes you wear, it's more that special way you look at me that always keeps me there. Whoa, you are the woman that I've always dreamed of. I knew it from the start. I saw your face and that's the last I've seen of my heart. It's hard to tell you all the love I'm feeling, that's just not my style. You got a way to set my senses reeling every time you smile. Whoa, you are the woman that I've always dreamed of. I knew it from the start. I saw your face and that's the last I've seen of my heart. Of my heart. Ooh, of my heart. Ooh. I saw your face and that's the last I've seen of my heart.
Identify the two major branches of the common iliac arteries. All right, let's find those. Aha, here they are.
The city streets are empty now. The lights don't shine no more. And so the songs are way down low.
The azygous. Oh man, no one ever talks about these, but they're so interesting. They can connect the superior vena cava and the inferior vena cava through the back of the diaphragm. It's like a secret. Let's look at some more veins and how we get back to the heart. We're going to study some of these in the future. In the future.
And now, the Jefferson Starship.
The aorta is an elastic artery with huge, fast blood flow.
Is it ready, willing, overtime? Where does it stop? Where do you dare me to draw the line? You got the body, now you want my soul. Don't even think about it, say no, go. Yeah, I'll do anything that you want me to. Yeah, do almost anything that you want me to. Yeah, but I can go for that. No, I no can do. I can go for that. No, I no can do. I can go for that. No, I no can do. I can go for that. Can go for that. Can go for that. I can go for being twice as nice. I can go for just repeating the same old line. Use the body, now you want my soul. Oh, don't even think about it, say no, go. Yeah, I'll do anything that you want me to. Yeah, I'll do almost anything that you want me to. Yeah, but I can go for that. No, I no can do. I can go for that. No, I no can do. I can go for that. No, I no can do. I can go for that. Can go for that. Can go for that. Can go for that. No. Yeah, I'll do anything that you want me to. Yeah, I'll do almost anything that you want me to. Yeah, but I can go for that. No, I no can do. I can go for that. No, I no can do. I can go for that. No, I no can do. I can go for that. Can go for that. Can go for that. Can go for that. No. No, I can go. I can go for that. No, no can do. Go for that. No, I no can do. I can go for that. No can do. Forget it, bad, no go. Forget it, bad, no go. No, 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 no can do. Forget it, bad, no go. Forget it, bad, no go. No, 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 no can do. I can go. I can go. I can go. Go for that. No, no can do. I can go. I won't go. I can go. Go for that. No, no can do. Hey, I can go for that.
This is the part of the show that we're really excited about because we get to introduce the Jefferson Starship. This is Craig Chaquisto, lead guitar. And this is Angeli Dynabar, drums, in the back. On bass, David the Freiberg. There it is. Paul Canton, the rhythm guitar. Mickey Thomas, the vocals. Pete Sears, bass and keyboards. He also plays the piano. I like all of these people, all of them, but best of all, I like the little bird, Grace Slick. Anybody that could name their kid God is okay in my booklet, you know what I mean? Ladies and gentlemen, Jefferson Starship.
And those are red blood cells passing through. That's Oprah, by the way. Those are the red blood cells passing through. Okay, that wasn't, I don't know.